Good morning, everyone. And at the outset, I would like to thank Dr. Madhu for having me here. It's not showing up. Okay, so let's talk about strengthening opportunistic screening. So we already know that glaucoma is the second leading cause of irreversible blindness, which is preventable. And as we just heard, that in both the developed world as well as the developing countries, more than 90% is undiagnosed. Patients are unaware of the disease. And by 2040, it's projected that around 112 million will have glaucoma. And it's high time we start thinking about screening and preventing the disease and catching it at an early stage. So the settings, as we just saw, were a community setting. This can be done for all individuals or only the high-risk individuals. Community-based screening does come with its challenges, as ma'am has very nicely pointed out. The most important being cost-effectiveness, and other issues are the lower prevalence and the impracticalities of certain techniques. So recently, it's a good time to talk about this because just in May, the screening guidelines for glaucoma have been published in JAMA by the updated evidence report and systematic review for the US Preventive Services Task Force. And they said, they did a meta-analysis, and they said that insufficient evidence was there to recommend for or against routine glaucoma screening. But here we should clarify that there the screening was only for primary care physicians, not for community and not for the eye care professionals. And the American Academy of Ophthalmology does recommend a baseline comprehensive eye examination at 40 years of age for everyone, and that is opportunistic screening. And then routinely, with increase in age for people with risk factors. So in the future, with better cost effectiveness and better study designs with AI, with teleophthalmology, community-based screening may be a better option, but currently opportunistic screening is the available and feasible option. So what is opportunistic screening? It is the active detection of glaucoma when patients visit clinics and hospitals or when they come in contact with any type of healthcare and we check them for glaucoma. So a simple way would be when they come to any ophthalmologist for a spectacle checkup or a general checkup, optometrists, physicians, diabetologists. We can be innovative, like when they come in contact with their physicians, healthcare personnel, even their dentists. And like we just saw beautifully in the Pondicherry model, we have to be innovative and think out of the box depending on the situation, because India is diverse in many ways, socially, economically, geographically. So simple thing is that, I don't know how many of you would have renewed your driving license. So after 50, you need to do that. And after 40 years of age, you need to give a certificate which includes measuring your eyesight by a registered medical practitioner. This can easily be clubbed with a comprehensive eye examination to detect absolutely any eye disease. So this is one example, and we really have to think depending on the situation. So the advantage of opportunistic screening is that first, it's the patient who's actively involved. They are the ones who are seeking the care, and they are more likely to listen to you. It's readily available, the specialized staff, the equipment, because the prevalence will be more, there'll be a better predictive value. And here the patient is bearing the cost. So there is a low cost to case detection. But then that can also be the challenge, that's the flip side of the coin. So moreover, non-ophthalmic medical facilities are more readily available, accessible, and in greater number than ophthalmic facilities. Now let's shift to, and in developed countries, more than 50% of cases are detected through opportunistic screening. So what do we do at the ophthalmology level? Any patient who comes to an ophthalmologist, like we just discussed, at least tonometry, gonioscopy, and optic nerve head examination should be done, and visual fields if required. And the challenges are there because there are lack of facilities for comprehensive ophthalmic examination. The number of practicing ophthalmologists are more in urban India rather than rural. And there's a non-standardization of examination techniques which may miss glaucoma, especially gonioscopy, because in the Chennai glaucoma study, we found that a significant number of patients diagnosed as primary open-angle glaucoma prior to examination actually had primary angle closure glaucoma. And similar results have been seen in the West also. So how do we strengthen it? We really have to make guidelines and standardized guidelines for a comprehensive eye examination for any person who comes for an eye checkup. And this also, apart from the standardization, it also needs imparting the skills. We have to accept that it is unequal, so we need to give training also. So when we shift to the primary care clinicians and health workers, the challenge there would be that they don't have an ophthalmic infrastructure. They may not have knowledge about the disease itself, and they may think, it's not my field, so why should I bother about it? It's not my problem. But then, as in the Dr. Jampel in this review recently published, pointed out that they can just ask 3 questions in the history. Have you ever been told that you have glaucoma? When did you last have an eye checkup? And do you have any family member with glaucoma or blindness? Just these three questions by their primary care physician, or like ASHA workers also, like ma'am said. They are the ones who are in regular contact with the patient, so they will motivate them to seek further care. So this has to be accompanied by a referral framework for further evaluation. And as we just saw, cataract screening camps are a very good opportunity to screen for glaucoma also. And both are a disease of elderly population. And a significant proportion of those who had undergone cataract surgery in our rural cohort of Chennai glaucoma study had glaucoma. And cataract screening may be the only point of contact with eye care. So the patients who come to our community center for a cataract surgery, 8% of them were diagnosed with glaucoma. And similar percentages have been noted in other parts of the country, ranging from 2.3 to 4.7 prevalence rates of glaucoma among cataract patients. And this is all well said and done, but we need to audit and assess whether it is taking place correctly and what are the drawbacks and how we can make it better. So vision centers, like ma'am and Dr. Venkatesh have said, that we can use them for screening for glaucoma when the patient comes, and they have a very good referral framework supported by teleophthalmology. And in a pilot, we found that about 70% of the referred patients at the vision center did come to the main hospital, and 90% of them were diagnosed with glaucoma. And going further into rural India, where you have geographical challenges, we have mobile surgical units which go and do cataract surgery there. So this is always clubbed with a comprehensive eye examinations where we can pick up glaucoma patients as a part of opportunistic screening. So basically we have to, it has a theory of planned behavior or a whole practice approach. It's not only the ophthalmologist or the clinician, they should even involve the team. Maybe even the receptionist can just, tell the patient in the waiting area or their attendant that, would you like to have a glaucoma screening? So you have to address it at each level, break it down at the patient level, provider level, infrastructure, and policy level. So if you look at the patient, he goes through many stages psychologically. He may be totally unaware that there is a glaucoma screening, or he may be undecided. He may be deciding to act, and there's a gap between acting and actually intention to act and actually doing the screening. And finally, once the screening is done, we should not leave it there. They should be recalled for screenings because it is a progressive disease. And we can address the challenges at various levels by increasing the awareness by various innovative ways, by healthcare workers, by increasing better access to the services. At the provider level, like skills training and reminder strategies, patient navigators, and finally, assessment and incentives are important. And basically, we like to increase the awareness in the media by various ways, develop human resources for eye care, strengthen the service delivery, develop institutional capacity, review and assess the impact. And like Dr. Venkatesh and his team just showed that they gave a sapling. We need to nurture that sapling by reviewing and revisiting the program again and again. Thank you very much.
Thank you, Mona. You've really picked up